Matt.
Yes, sir.
You want me to advance your slides, or do you want to take over, or want me to stop sharing and you share?
I can share.
Probably better if I went ahead and advanced them for you.
I'm trying to think what would be better for you for the recording.
Probably better for me just to go ahead and advance it as you tell me to.
Okay, sounds good. The videos are a little bit weird sometimes of where you click, but hopefully it works out. If not, I'll take over.
Okay, we'll figure it out.
Cool.
I did watch them earlier. I looked through the whole thing, so.
Awesome.
All right, guys, good morning. We're gonna go ahead and call the meeting to order. It's 9 o'clock. December 13th, it's the last one of the year. Just to let you know, we will continue to do the even months here at Union Hospital starting in February. I believe Regional Hospital is trying to do something. Maybe they'll start again in March on the odd ones, but we'll wait and see. That's what I was told this morning via text message from Zach Forley. He's stuck in work, but he said he's working on trying to figure out what they're going to do down there. He would like to do something starting on the odd months in March. We'll see how that goes. But as of right now, you'll at least get 6 of them from here. We will be meeting here. They will still be Zoom and they'll still be recorded, but I'd love to start seeing more people here face to face. Breakfast is pretty good, right, guys? So
Yeah.
anybody that showed up, breakfast is really good, by the way. So yeah. So, anyway, we're going to do that and continue to have that. So we'll start right off with the STEM report. It says Brenda and myself. Brenda did the report. She is in neck brace and having some x-rays done this morning, so I told her I would go ahead and present it. I looked through it a little bit, but I don't. Wow, that's really touchy. All right, so the EMS run is 0310 in the morning. Dispatch via 911 to home for a male with chest pain. Arrived at 327, 59-year-old male, conscious and alert and oriented times 4 sitting in a chair. Skin pink, warm, slightly diaphoretic. Patient writhing in pain and unable to sit still. Rapid, shallow breathing. Had to coach the patient to slow his breathing down. Patient states he was lying in bed when he had a sudden onset of sharp chest pain that radiated down both arms. Patient wearing a Holter monitor and a life vest combo. Red flag. This is all that. All right. So at 329, the vital signs were 142/94, heart rate at 104. A little agitated, a little bit. Respiratory at 26. He had 93% room air. 98.3 temp. I'm guessing, and blood glucose was 115. Rate his pain at 8 out of 10. They put him on a 3 liters nasal cannula. Aspirin at 324 was given. 20 gauge IV started in the right AC. 12 lead obtained showing ST elevations in 3 and AVF with widespread ST depression. 12 lead indicative of an acute inferior MI. Patient was treated as such. Looks like Zofran 4 milligrams administered. Fentanyl 50 milligrams administered. Nitro held due to risk of hypotension. Okay. At 359, vital signs now at 136/94. Heart rate stayed the same. Respiratory rates at 28. He has 99% with that oxygen on there. Pain still 8. Another 12 lead attempted. Patient unable to sit still. Too much artifact to determine there are many more changes. At 4 o'clock, they gave 50 micrograms of fentanyl again. Terre Haute Union Hospital alerted the patient situation utilizing eBridge app via cell phone. Report called the Union beat IHERN and code STEMI was activated. 417, they arrived and transferred to trauma 1. 18, the ED determined past history of cardiomyopathy, coronary artery disease, congestive heart failure, smoker, cannabis, and methamphetamine abuser. Hello. Head and neck and cancer also. So patient arrived in procedure room at 509. Balloon catheter advanced to the target vessel. 533, a stent advanced to the target vessel. Successfully stented the drug-eluting stent placement to proximal and mid-right coronary artery, reducing occlusion from 80% to 0. EF of 10%. So yeah, that's not so great anyway. So patient strongly advised to quit smoking and go ahead and stop using the meth. And discharged 2 days later. Hopefully to on high intensity statin therapy. Door to balloon time was 66 minutes. He included for this. So for the life vest combo, this particular person obviously had some issues. All right, right off the bat. The patient has had a Holter monitor on. They're monitoring for 24 to 30 days. This is 24 to 48 hours. I've seen him wear them as long as 3 weeks, 2-3 weeks. I've heard. So we're on a Holter monitor to keep track of 24 hours, 7 days, 7 days a week, to keep track of their rhythm, see what they're doing. By wearing a life vest, I'm 100% sure this person was going to some VTAC, some VTAC with a pulse, or they're really worried about a VTAC without a pulse, and they're going to shock them. That's what the life vest is going to do. It beeps and lets them know, hey, by the way, we're getting ready to shock you. There is a way for them to shut that off if there's a problem. Only reason my dad had to wear one time before he got his defibrillator put in, and so he had it on, and it would beep, 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 and he'd freak out. He'd shut it off. I'm like, that's beeping for a reason.
Yeah.
So, but he's sitting there talking to me. I'm pretty sure we're okay at the time. So, just she wanted to put this in there. I didn't mention it to you. So, yeah. So for September, we were 100%. We had a couple fallouts, but for the year to date, our door to balloon times within 90 minutes, we're at 97%. That's really good numbers. Still look really good for our STEMI accreditation. Those numbers are really good. Anybody have any questions on this at all? So the next thing is going to be Will Losey from Union Clinton. He's got, I think, 4 cases he's going to talk about. And Will, I'll go ahead and advance for you whenever you're ready for me to.
Outstanding. Yeah, I've got 2 from Park County and 2 from Ileana.
All right,
2 cardiac, 2 neuro.
here you go.
First case study, we got a 50-year-old male, had a history of CAD, had an AICD placement, sick sinus syndrome, history of TIA, CHF, hypertension, AFib, PE, factor V deficiency, cardiomyopathy, and cochlear implants. He had gone to lay down as he was not feeling well. Family later found him passed out on the floor.
Can't understand him not feeling well. I don't forget this.
EMS was notified at 17:26, arrived on scene at 17:30. They departed the scene at 17:48 and arrived here at Union Hospital Clinton at 18:50. So they originally were dispatched for an unconscious person, arrived on scene, found a 50-year-old male lying supine on the floor. Family stated that he wasn't feeling well, had gone to lay down. I reported he was at the back of the apartment, found passed out. On initial assessment, patient was responsive, pink, warm, dry, breathing normally, strong radial pulse, no signs of trauma. Patient was asked to open their eyes and he was able to follow all commands. Able to stand with assist ×2, sit down on the cot. They did a stroke assessment at the scene, noted right-sided numbness. He had a paced rhythm, blood glucose of 93, no other complaints. On reassessment, he had developed a headache, 9 out of 10, no other changes. And they noted further into the transport that he developed right-sided leg weakness as a new development on the way in. Was unable to lift his leg off the cot. Stroke alert was called. It was brought in, taken directly to CT, and passed off to the nursing staff without further incident. So here at the hospital, stroke alert was called 18:17, taken directly to CT. They did note that he had artifact due to his cochlear implants, but otherwise no acute process noted on the CT. NIH of 9. Teleneuro was consulted. The patient was on Eliquis, so he was ruled out as a TPA candidate. Ended up being transferred to Union Hospital Terre Haute for MRI and further CVA workup. At Terre Haute, had an echo done, 45 to 50%. They were unable to do the MRI due to his cochlear implant and AICD. Neurology saw him, diagnosed him with migraine headaches, with a hemiplegic migraine. No deficit upon their assessment. He was started on Topamax, resumed Eliquis and atorvastatin, was scheduled for an EEG, but ultimately left AMA prior to that testing. So when I was going through that run report, one thing I really noticed was that the crew did a really good job calling out, neuro changes in the process of their transport here to the hospital. Our second case was a 54-year-old female, history of TIA, chronic back pain, hypertension, and seizures. Called 911 30 minutes after onset of headache with right-sided facial numbness. EMS was notified at 19:31, arrived on scene 19:37, departed scene at 19:49, and arrived here at the hospital at 20:15. The call was for a 50-year-old female, possible stroke symptoms. On arrival, she was alert oriented, no acute signs of distress, sitting in a kitchen chair with her husband. Warm, pink, dry, pearl. States that she had numbness on the right side of her face and a headache in her right temple. Vision seemed slightly disturbed towards the right. Onset was 30 minutes prior to call. She describes a headache at a 6 of 7 on a 10 scale, which improved while she was being transported. Long history of traumatic back injury, complains of chronic back pain with right shoulder, right neck. Vital signs were monitored, respiration, heart rate monitor. IV was placed prior to arrival. CT of the head was negative here. CTA head and neck also negative. NIH score of 0. Symptoms resolved while she was in the emergency department. She was actually boarding with us to get a bed at Terre Haute. Spent the night symptom free. Next morning, she requested that she be released and to follow up with neuro as an outpatient, and ERMD was agreeable to this plan. So she ended up being discharged with neuro follow-up from the emergency room. And one thing we were pushing with education for our local units here was making sure that they get those Cincinnati stroke scales or VANS assessments into the record. And this particular record had both. My third case, we had a 56-year-old female, history of arthritis, asthma, hypertension, seizures, had a VP shunt, type 2 diabetes, woke at 4:30 in the morning with a headache, elevated blood pressure. So she called 911 shortly after. They were called at 7:55, arrived on scene at 8:07, departed scene at 8:16, and here at the hospital at 8:36. So call for a 55-year-old female, complaint of high blood pressure. On arrival, she was walking to the ambulance with a first responder that had shown up prior. Alert oriented. States she woke at 4:30 with a headache, elevated blood pressure, approximately 220 over 120 with her home monitor. She took extra metoprolol, went back to bed, hoping that that would resolve the issue. Got up later at 7:30 to go feed her chickens, and noted that she felt roughly the same. So she called 911 at that point. Headache, had some minor shortness of breath and chest pressure. Relates headache anywhere from a 4 to 8 on a 10 scale, and chest pressure anywhere from a 2 to 4 on a 10 scale. They obtained vitals on her, put her on the monitor.
Sorry about that, Will. Hit the wrong button.
You're good, brother.
Good there.
So EKG, sinus, CT of the head negative, troponin series negative, chest X-ray negative. Treated with Tylenol, Norvasc, Dex, Benadryl, Compazine. Aspirin had already given prior to arrival from EMS, and her symptoms resolved while she was here in the hospital. Got some medication adjustments and ultimately was sent home. So on this one, they just noted that the call out was for blood pressure, but when the medics assessed her on the field, picked up on the chest heaviness and kind of shifted over to a chest pain call. Our last case is a 62-year-old female, history of anxiety, COPD, CAD, depression, diabetes, hypertension, hypothyroid. Called 911 45 minutes after onset of chest pain. EMS notified at 16:37, arrived on scene at 16:53, departed at 17:10, arrived here at 17:50.
Whoa, wait. I didn't do that.
There we go. So dispatch for chest pain. On arrival, 62-year-old female, conscious, alert, pink, warm and dry, breathing approximately 18 a minute, pulse of 80, complaining at a 5 out of 10 substernal chest pain that started 45 minutes prior. Pain worse with deep inspiration, did not radiate, self-administered 2 nitro without relief. And the first responders had also given 324 of aspirin prior to EMS arrival. Once in the ambulance, vitals above were taken, IV started, placed on a cardiac monitor, ran a 12 lead, blood glucose 275, and given 1 nitro on the truck. EKG was a sinus rhythm with the left bundle branch block. Troponin series ended up being negative, chest X-ray negative. Aspirin prior to arrival, no further medications in the emergency room. Admitted overnight for chest pain observation with no further episodes. Seen by the hospitalist the next day, negative workup. She'd had a lot of life stressors and was ultimately discharged home. One thing they did note, checking the expiration date on the patient's home nitro, discovered that it had been expired. So given that 3rd dose off of the truck with the good nitro, just to make sure that that didn't change any symptoms, I thought was a good catch by the crew.
Yeah. Anything else, Will?
That's it, brother.
All right, thank you very much. Appreciate it.
Thank you.
Next up is Tina Hedges. She's got a couple of case studies she wants to do for trauma. Yeah, trust me. Just had it once though.
Everybody hear me? Alright. So this first case, there we go.
Thank You got it. Yeah, there's a delay. Quick,
That's,
you. No more time. Actually.
yay, okay.
Just stop. There you
There.
go. Stop, push.
I had to get nothing. Okay, this first one, the case study, this was from September this year. A 63-year-old male with a moped accident. 911 call came in at 17:27, dispatch 17:28. We're en route at 17:28. On scene 17:29. They left the scene at 17:44 and was here at Union 17:59. Called dispatch was 1 minute, dispatch en route was 0. En route to arrival on the scene was 2 minutes. They were on the scene for 18 minutes, and then departure to arrival in ER is 11 minutes. Total time was 32 minutes. It was, they called in a level 2 activation. EMS report, he was found on the ground next to his moped. Lost control going 30 miles an hour and injected onto the street. Wasn't wearing any protective equipment. He was confused. GCS was 13. He was diaphoretic. Blood pressure was 152/80. Back was atraumatic. Chest had no deformities. The fish were stable. He did tell him he'd been drinking, but wouldn't tell him how much. He was upgraded to a level 1 on arrival due to hypotension. His blood pressure here was 66/44. They started IVs, gave him a unit of packed cells. He had an avulsion to the forehead above his right eye, laceration in the right ear, partial removal of the earlobe, 1 to 2 centimeter laceration to the upper lip on the right side of his nose, road rash to his knees, hands, wrists, left shoulder. But while EMS was bandaging him, he kept reaching into his pocket. So they wanted to know what was in his pocket. There we go. And they found a knife, a loaded pistol, a spare loaded magazine, and clips in his shorts. So the weapons were removed by EMS. Gun was found to be loaded with a round chamber. Magazine was ejected by EMS. The bullet was removed from the chamber. They placed a C color on him and kept pulling it off, so they took it off. And the arrival here was delayed a little bit because they were waiting for the police to get there to get the weapons. Got here 18:03, had lacerations to the left side of his face. Vitals were, this was later, 72, pulse 12 rest, 139/97. He was 100% on room air. Diagnostics, he had CT of the head, CT of the spine, max facial, CT of the chest, abdomen, pelvis, and his alcohol was actually negative. The diagnosis was motorcycle accident, complex facial lacerations, complex ear lacerations. So he went to the OR for repair of the facial head and ear lacerations. So he was and they ended up writing his discharge the next day, but he signed out because he didn't want to pay for the medicines that we were providing for free from the pharmacy. That's kind of the end of that one.
Not at all surprising.
I know, yeah. So if anybody have any questions?
Did he lose
or-
his ear?
I believe so, yeah.
Some part of it. anyway.
Yeah, so I did have a question, just because I'm curious, like EMS took the gun and, just got the
Cleared
clip
it.
out of it and stuff, is that normal? Or is it typical they wait and just give it to, I was surprised the police went there already, but.
Yeah, I'm surprised that there wasn't police officers on scene either. I think it just depends on how comfortable the EMS person
I was
is.
just curious, because I'm
Yeah.
like, if it wasn't me, I'd have pushed it away and
Yeah.
waited for him, but.
Yeah,
Minor.
some
Is it
some
kind
some
of
comment
dependent on whether you're comfortable with it?
some comments on this case. I cringe every time I hear of anybody on a moped. I just totally cringe. And they're going to be drunk as a skunk, or we're drunk as a skunk, or their liver's going to be 5 times bigger, and they bleed like just bleed like hell, and they've run into something, or they've run into a train. I mean, that's moped beats train is about the worst one, I guess. But they look like the ambulance did, the ER emergency crew did real well on this, and it's good they found these things. It's interesting what sets in on people. I mean, if they were paying attention, that thing would have been right in our ER with a drunk person holding it.
Yeah.
So
That's a
it's
good
really good that they got that picked up, and they got it all picked up in a very reasonable time there, it seemed like. And the guy did get hypotension, got upgraded to 1. This is the type of guy that gets us in a lot of trouble with the college, because he doesn't look quite like a lot, but he's a lot. And then he shows a little deterioration, and on paper, this guy looks like crap. And when somebody comes and reviews this, if they didn't upgrade that to 1, that is a major citation right there. So thank goodness got upgraded. I don't know who the ER doctor was, but they did good. They upgraded it to 1 when it was necessary. There's nothing wrong with people changing their minds, as long as they got a good reason to do it. So blood pressure is 60, good reason to be changing your mind if you can. Look like an all-around pretty okay case. It's just kind of what these people do. I mean, they're non-compliant. They're going to try to pull anything off on you they can, and they're like I said, this is one of my really cringe if I hear about moped. They've lost their license for DUI. That's why they're riding a moped. Who else would ride a moped in Indiana in the winter? So I really dislike this group of people. I'm right out there with it. I see my partner in the hallway. Could you go see his level 1 trauma alert for me? It's a moped injury. Yeah. So okay, next case. Thanks. The case there.
All right, oops, sorry. Okay, this next one we presented at Topi last month, and it's just kind of just to let the EMS crews know that they did a really good job on this. Everybody that was involved with it did it. It was a good outcome. It's like a feel good kind of story. So this was a 32-year-old male. He had a gap wound to the chest. This was from August, I think. It was accidental, self-inflicted, true story. Patient, he works as a butcher. He was from Clinton. He was butchering a cow, and this is from the ER record, said he slipped and fell on the knife. We spoke to the patient later. He had one of those butcher aprons on, and they have a slit where you can put the knife in. And that's what he did. He bent over to answer the phone, and the knife went right in his chest. So, yeah, that's what we said. Patient, he went to Clinton, his brother drove him, I believe. 1626, his vital pressure was 87/50, 102, 25 rest, 100% on room air. They did lab, EKG, chest x-ray, MTB was activated, TXA. Called dispatch. Now this was from Clinton when they called to transport him here. 1701 dispatched en route was 1702, en route to arrival Clinton was 1703. They were there for 10 minutes, left at 1713 and got to, or 1727, came here. And in total from the 911 call was 26 minutes from the time they got that call, got the plane. Yeah, it was a very good thing. So there was, there. Okay, so he had pulled out the night prior to coming to the ER at Clinton. They gave him 2 units of pack cells, went, gave the medic crew 1 unit to give en route. He had 2 liters of saline and TXA was given. There was a delay in flight time. I think they said because of the weather, if I remember. So they wanted to send him to the nearest trauma center, which was us. They had normal saline wide open, they had him on the monitor. The chest x-ray at Clinton showed a tiny apical pneumothorax. That was 86 when the medics got there. They put him on 4 liters, got him up to 92. Oh, what that little was. 93 over 64, pulse was 106, rest 20, DCS was 15, his pain was 6, his sinus tach, his alert and oriented. They called IHERN to Union ER in Terre Haute with a level 1 activation. He got here at 1733, Dr. Rees and Dr. McDonald, who was a locum cardiovascular were present in the trauma room. I think Dr. Lynch made a stop in there too. But they were sitting in the trauma room waiting for him to get here. When he got here, he had a small wound about 2 centimeters, the peristernal aspect.
Yes.
The left anterior chest wall, the 4th intercostal space. Wasn't any bleeding, it was clean looking. He had decreased breath sounds on the left compared to the right, slight deviation of the trachea to the right, decreased wall movement on the left, breaths were moderately labored. When they brought him into the ER, he was gray. Me and Jackie were standing there and we both went, uh-oh. It was one of those, you knew it was gonna be bad, but he was awake. He was alert, warm, dry, and pale. He was very focused. You could tell he was trying to keep himself calm. He was 97 pulse, 18 rest, 90 over 58, 98% on 2 liters. They continued the MTP. We gave him 2 more units here. Diagnosis was the hemothorax, hemorrhagic shock, pneumothorax on the left, and stab wound of the chest. Repeat chest x-ray here showed an increased size of the left pleural fluid with mass effect, left to right mediastinal shift. We placed chest tube. Dr. Rios said got 2.5 milliliters or liters of blood back, and I mean it shot out. It was all over everything. Post chest tube showed the approximate placement and continued to have complete whiteout of that left lung. Bedside fast showed free fluid around the left lung. There wasn't any pericardial fluid or tamponade, but they were still kind of concerned because it wasn't really visually, couldn't see it real well. So he was taken to surgery with Dr. Rees and Dr. McDonald. They found a transection left internal mammary artery and left lung laceration, profound hemorrhage. At one point in surgery, Dr. Rees said his pressure got down in the 60s and they were pumping him full of blood. He had an emergent median sternotomy, mediastinal exploration, ligation, repair of the left internal mammary artery, repair of the left lung laceration. He had 3 chest tubes put in. And in OR, he was given 12 units of packed cells, 7 units of plasma, 2 platelets. Estimated blood loss was 4,000 in surgery. So together he lost over 6,000 blood, and we gave him like a total of what, 15, 16 units of blood plus platelets, plasma. He went to ICU post-op.
Holy shit.
There we go. Post-op day one, he was awake, he was off his sedation, he had no pressors on, had him through the night. I went out and saw him at 8 o'clock, he was awake, was still intubated, but he recognized me because I'd been talking to him the whole time in ER. He grabbed my hand. They extubated him, he was on 40%. That afternoon, I went back up, he was in the chair, he was taking fluids, he was eating. His pain was controlled, IV antibiotics. Post-op day 2, they consulted ID because there was a dirty knife, of course. Still pain controlled, room air, sat 97%. They transferred him to PCU. Third day, all the chest tubes were out. He was still on IV antibiotics, pain was controlled. Post-op day 4, consulted at IR for PIC placement, case management, was working for home health care and IV antibiotics. Next day, the PIC was placed. He had 5 to 6 beats of VTAC when he was lying on his left side. So he turned over and nothing, they didn't have to do anything. Didn't have any more events like that. Day 6, it was 6 and 7. We was waiting for approval from VA, of course, waiting for approval for his antibiotics and home health care. Day 7, he had a good appetite. He's up walking around by himself. He discharged home with his brother, and they set up home antibiotics and home health care. And he followed up with cardiovascular and ID and trauma. I mean, it was amazing. And Dr. Reese had told us if they really had tried to fly him, he didn't know if he'd have made it. And I mean, this guy, he was amazing. And like I said, he was real focused. You could tell he was just really focused. And I told Trent, I thought he must have been like in the Army or something. And he said he was like a medic type person in the military. And he knew, he said when they were bringing him here, every time they hit a bump or they turned, he could feel that fluid moving in his lungs. And I'm like, that had to be the craziest feeling. But like Dr. Lynch had said, it was just that little tiny artery. And I was like, who would have ever thought that could do that much damage? But anyhow, it was a really good story. So I just wanted to share it with all you guys because he made a huge difference getting here so fast. So.
Thank you very much, Tina. Appreciate that. I'm pretty sure it didn't hurt that that guy was healthy otherwise.
Right.
That makes a huge difference.
Yeah,
for
yeah.
recovery, too.
Yeah, he's a little bitty guy too. He wasn't as big as I am. Yeah.
Hello. Yeah. Yeah, that everything worked well and it was a good save. It's a nice case, very nice case. It shows why we need to keep after some of these that don't look like they're doing so well, you know. And it's amazing how small an injury actually can kill you because this artery is only the size of your radial artery. But you cut your radial artery, somebody puts their thumb on it, and that's the end of it, you know. And you cut your radial artery in your chest, nobody even figures it out for about an hour exactly what it is, you know. And then they tie it off, you know, but it takes that long to get to that point by the time you go through all the steps. This is very small. All the big stuff there is in the chest, and they almost bled to death from a 2 millimeter vessel. That's the same size as a radial artery.
Wow.
You know, so and then this guy's young. If this guy was 80, he still would have died from kidney failure and pulmonary failure from shock, from the hypovolemic shock. But this guy's young, and age is absolutely amazing. So really nice that everybody stuck with this young kid and, you know, got him where he needed to be, to who needed to be with him. Yeah. So good case, good save.
Appreciate it. Thanks, Dr. Lynch.
Mm-hmm.
Dr. Malamed, you are up.
Fantastic. Thanks, Barry. Thanks everyone for all your fantastic reports today. I think this education always goes in a far and exceptional way to get everyone at the same page. So it's great. But so I wanted to come back and talk about some basics, and I like to take it back to good patient reports and good patient handoffs. And that means both our Einhorn reports to get, you know, the great kind of report that we need prior to somebody getting to the hospital, as well as what's our bedside report. And then I'll touch on some medical control cases. When you call me up and you ask me for something, you know, I can help you out as best as possible if I get a nice succinct message, especially if it's like 2 or 3 in the morning and you know, somebody's getting woken up and it's probably me. It'd be nice to have a quick and succinct story comparatively something that's a little bit all over the place, and I have to sit there and try and really get a grasp of what's going on. Can I get the next slide, Barry, please? So here's some things that you may not want to say either in front of your patient or to the patient. Go ahead and play it, Barry.
That's how I finally managed to get my paramedic license back. Oh man, I said you suck, not give him sucks. Wait, did you say 2 milligrams or 0.2 milligrams? Bad news is you've lost a lot of blood. Good news is we found it. Did you catch Station 19's episode last night? That show is amazing. Nah, that can't be right. I've never seen a person with a blood pressure that low still be conscious. So on a scale of 1 to 10, how up to date is your will? How bad is it? I mean, what do you consider bad? What? Sir, how many fingers am I holding up? Okay, potato is not a number. Yeah, St. Mary's, this is Rescue 27. I need you to have everybody ready.
All right, next slide, please. So as you can see, right, we can say some of the wrong things that will get us either in trouble, right, in front of the patient, or will get us in trouble with, not in trouble, I'm sorry. We'll just not convey the information we want to convey. So we want to say the right things when we're either talking to the patient or when we're talking at bedside or when we're giving your IHERN report, so that everyone is getting the right story of what's going on. Can I get the next slide, please, Ben?
I'm
No,
trying,
sorry. No worries.
but holler at me.
Click.
Wow,
Yeah, click outside of the video, or try that one. There you go.
come on. I don't have time.
If it doesn't work, I can always share mine. And
You gotta be kidding me. What'd you do?
I didn't do anything.
You wrote it.
Right here, if you want, I'll share my screen.
Okay,
All right, give me 2 seconds.
stop sharing then.
You got it.
If I get this to work. Really, struggling here.
Okay. Can you guys see my screen?
Yes.
Great. All right. So this is a real life example of an IHERN report. And I just want you to don't worry about the medical stuff that they're presenting. I want you to just think about the story and how they're giving you the story, right? And think of, if you're the person on the receiving line of this story, is this how you'd like the story to be given? And what would you do better? And this is never a knock on whoever's doing it. I've taken on anybody's names or unit numbers. So that's not going to be in there, but I want you to take into consideration, would I want this story to be this way? And what could I change of this story to make it sound better for everybody?
Good evening, Ian. We're about your facility with a 53-year-old male patient coming to you out of his residence today. We're going to be calling a stroke alert. Patient has no control over his left side, has slurred speech, and is possibly becoming altered. Also, he's been sick for the last couple of days. Lung sounds are diminished in the lower fields. I've given a duonab with an extra albuterol. Finger stick is 121. Vital signs is AFib with RVR from the 80s into the 130s. Last blood pressure is 164 over 131. With the neb, we've got 98%. He's normally on 4 at home, and he has a medical history about as long as my forearm. We're going to need to give about 5.
Could you repeat that blood pressure, please?
164 over 131. So I'm getting the moment not able to take a manual. Also, he is on blood thinners, and this started approximately 40 minutes ago.
And he has no movement. He has disregard for the left side.
Yes, left side is not very functional.
What thinner is he on?
Possibly eloquence. He's really slurred speech.
Sorry, can you repeat?
Possibly eloquence. Really hard to understand. Really slurred speech. Also be advised, the last blood pressure I was able to get was 127 over 74. So
See on arrival.
thanks. Good evening, Ian. We're about your facility.
if I can get, what are your thoughts about this? You can either put them in the chat or unmute yourself and give us a little bit of feedback, but give me your thoughts on what you think. And just keep in mind, so this is, for example, this is the sheet that we utilize when somebody comes in for an IHERN. This is what somebody's kind of writing down everything that's there as you describe it. So what do you guys think? What would you take back and say, I like this, how this came across, and I don't like how that came across? And this is the interactive portion of the class or lecture.
I would say for me that it didn't have like a cohesive flow throughout. It seemed to kind of jump around to different thoughts.
Okay. All right. So not as cohesive as we'd like. What else?
I did like the fact that he did call in a stroke alert. I mean, that's a good start.
Absolutely. Yeah. No, that's a huge plus. I'm super happy about that. Did you guys feel like he felt calm giving this report? I didn't get a sense of calmness. I didn't get a sense of, I want to have a sense of both calmness and control when we're giving our reports, right? I didn't get a sense of calm. I felt like he was quite rushed. And sometimes you just got to you can convey the same amount of information in a way better way. If you take a minute, you take a breath, you say to yourself, okay, what do I need to call a report in about? And then you give that report almost in your own head, then actually talk it out. And that's going to help you tremendously, right? So we're a little bit rushed to the point where he's got this long medical history. Well, that, some of those things may be really important for us to know as we get ready for what are the things we need to do. And it's great that he caught that the person's on Eliquis. If you're ever unsure, and this is just a general tidbit, if you're ever unsure about somebody's medications, while you're doing things, have somebody tasked with taking a pic, either grabbing the patient's medications with you and bring them. That's super great. Or two, if you're like, man, there's too many medications here, they're spread all over about, just take a couple pictures with your phone, right? And bring those in with you. Obviously, we'll delete them afterwards, but this way I know I can see, oh, I see Eliquis there. I don't see Eliquis there. I see this, I see that. So those are all really super helpful and handy things to try and get to us what we're trying to capture. And I agree, Jennifer put up here, it's a little disorganized, and it was a little disorganized. Overall, actually not horrible, right? I've listened to a number of other horrible kind of presentations from across the country. It's not like just ours, but it wasn't as ideal as it could be. And we can tighten this thing up. And I think if we tighten these things up, both on the IHERN and our bedside handoffs, we're going to do a lot better for our patients. So how should we tighten this off? Now, this EMS timeout report is something it utilizes something called MIST, and MIST kind of looks at your mechanism of injury, your medical complaints, your injuries or illnesses that you saw, the signs and symptoms that you do in your treatments. And I like to boil this down to, hey, what went on, right? What's your exam like? What did you do? And what did that result in? Right? Those are the biggest things that I need to know. I could care less that you were able to pivot and turn and put the person on the cot. That's not going to make medical decision changes for me. I want to know, when you got there, what do they look like? What kind of vital signs do they have? What interventions did you do? And what did those interventions result in? Those are the most important things. And then if I can get a thought process behind why you did something, that would be key. Hey, doc, I saw this and I thought about this, but I didn't want to do this because I wasn't really sure. So that's why we didn't do this. Or I saw this, I thought that this was my most concerning thing, so I did this, and this is why we're at this point, right? And that can be both from a trauma or a non-traumatic injury, some sort of medical problem, some presentation, just so I understand your line of thinking. If I don't understand your line of thinking, to me, it's going to be like, am I getting a partial picture of what's going on? Am I missing something that you did that I'm not hearing about? And those are all key things. So if let's put it into two quick examples. First example, let's say it's a motor vehicle accident. These are the key things that I want to know, both at either bedside or via an iHearn report. Now, obviously in the iHearn, we're not using the person's name, but we can say, hey, this is a 26-year-old male, was a restrained driver on a T-bone accident, struck another vehicle going approximately 30 to 40 miles per hour, has some substantial damage to the front of the vehicle with about, let's say, 20 inches of intrusion into the cabin. Airbags deployed, patient is non-ambulatory, required a prolonged extrication period from the car, has, and then now what do we have? What do we have? Our injuries, right? So that's the mechanism. Now we got our injuries. On examination, patient has a substantial laceration to the forehead, approximately 12 centimeters in length, with some active bleeding, currently controlled with bandages, has no obvious deformities to the arms or legs, and has bilateral breath sounds, no abdominal tenderness, no pelvic tenderness. Pelvic binder was not necessary at this time. Vital signs are such: heart rate of 130, blood pressure of 60/20. I'm just making up numbers. Breathing rate of 40, and satting 75% on room air. We put him on a non-rebreather and it improved. Currently has these things in place. We've given him 100 of fentanyl and blah, blah, blah. And we're now en route, right? So you can adjust that to a bedside report, and that could have been an iHearn report. It took me all of 45 seconds to get the bulk of the information out there that was necessary. And it was fairly clear and concise, right? That's the important thing. You just take a second to stop, think about what the story that you want to give, and then give that story. But if you just get on the radio or you get to bedside and you're fairly rushed. Now, is this going to happen every single time out there? Probably not. Would I love for this to be like this 75% or more of the time? Absolutely. So what I would love for you guys to do is look at missed and stop in your head and go, okay, let me figure out my missed story before I call it over the radio, or I do it in person at bedside. And then I'm going to practice that in my head before I say it out loud. And that way you go, ooh, I missed the vital sign. Let me make sure I get that right. Because if you go back to our previous slide, right, you can see this is fairly organized. Outside of the O2 being kind of up here and the pulse ox being up here, everything else from your vital signs are here. So if you're kind of giving a chief complaint and then you're hopping into vital signs, it keeps it fairly disorganized for everybody. And also just from a flow perspective, it really does make more sense to give me what's going on with the patient. What did you identify in your exam? What are the signs and symptoms that you've found? And then what did you do to intervene on those things? Any questions about this? All right. So this is kind of the same thing, right? So I've boiled this down to these little tidbits here. And as you see, you can see what we're finding and what did we do, right? Did we do tourniquets? Did we do needle decompression? And what were our results of it? I put a tourniquet and bleeding stopped. I did a needle decompression, hypoxia improved, work of breathing improved. I needle decompression and it did not improve, right? All important things for us to understand of what's going on. So if you take anything away from this, this is what I want to think. And it's nice. It's so easy. It's missed, right? You can't get more. It's a one syllable word. So think of these things in your head first and then talk them out. Let me give you some examples here and let's see what you think in terms of some of these reports that people were given. This is like 7 years old, so not mine. I'm not affiliated with McLaren Hospital. Very dramatic music though.
Call myself a 107.
Sir, go ahead, please.
Hey, McClure, we got a party one time, McClure. Let me know when you're ready to copy.
Go ahead, I'm ready.
I got a male patient coming in, mid-60s, I'm guessing. He got on scene, found the patient to be, to have agonal respiration. I had a sinus on the 168. This person's got multiple injuries. His left leg is below the knee is fully degloved. He has several other obvious deformities as well. He has blood coming from his ears. He's clenched at this time. I got blood pressure 155 over 117, 155 over 117. Still showing 68 on the monitor. O2 stats are 98%. He's being back at this time. Continue further upon arrival. ETA about 5 minutes.
Very good, sir. Continue transport. We'll see you in 5 minutes.
So just to stop there, as a story, as a story in of itself, not too bad. Would I have liked a little bit more detail? Yes, but was he following kind of the missed mnemonic? Pretty much, right? Person has some injuries. He threw in some of these vital signs before he got to kind of his examinations, which I get, okay, not the end of the world, but kind of follows missed. Not super great, but a decent example of what I'd like to see in terms of continuity of what we're kind of presenting there. Let's hear another one.
Start off 101.
You gonna call McLaren, go ahead with the report?
Okay, I'm going to start off 101 and right with a party 230-30-year-old female. Patient restrained driver involved
Oh, sorry about that.
in a motor vehicle accident.
Sorry about that.
She was barely moving when she was T-boned by another car traveling approximately 20-25 miles per hour. Patient complaining of chest pain, saying she was hit with the airbag, side airbag, no front airbag deployment. She's out times 3, pain reproducible with inspiration and movement. No other, she's also complaining of some lower back pain, noted when she crawled into the passenger seat, no head or neck pain, no LOC. Blood pressure 137/83, pulse of 104 regular, respirations 18. Sinus check on the monitor, saline lack established, state 8 out of 10 pain. We're pulling into your facility right now. Do you require anything further?
Nope, see you on arrival.
Same thing, right? So decent story, a little bit better at taking that missed kind of mnemonic and really keeping to it as best as they could. It provided an ample amount of information of the scene of what I should get a picture of my head of, hey, what's coming in? How substantial is this traumatic injury that I should be worried about this patient or not, right? Any thoughts about that one, guys?
I thought it was good. Yeah, that was decent.
Okay, good. Let's hear another one.
On McLaren, call med stuff, or 117, party 1 second.
Go ahead.
McLaren, call med stuff, 117, party 152, type 0, male, 2.3, we transmitted to 12 leads. I do know on that is going to be 31153. First 12 lead is a regular 12 lead showing semi. Second 12 lead we sent you is actually right side of the B4. It does appear to be right side of that line. This time patient is in times 4 BCS at 15. Vital 21 pressure 136, 136 over 98. Rate 73. Minus rhythm on the monitor set 90%. Nasal cannula 4 liters. We have 324 amps on board, 2 IVs established. Patient takes the left side adjusting rating out of his left arm, 7 out of 8 out of 10 now. 1:30 this afternoon. History is hypertension. If you're going up, there will be there in about 5-7.
The patient, if you have the cardiologist, please.
The patient does not have a cardiologist. He only has no.
Okay, thank you. Let us know if any changes and we'll see you upon arrival.
Fantastic. So as you can see, like that one, not too bad. He was actually doing a great job, but would have done a little bit better when he kind of snuck in that little bit of stuff right after he did his medications and aspirin and nitro. Would have loved for that little bit right after that to be back to the right position. But the rest of it actually was pretty good, right? So you see how doesn't sound flustered really, doesn't sound out of breath, has a fairly good grasp of what's going on, has even taken the point of asking the patient who is cardiologist or a primary care doctor would have been all helpful things for some of these kind of situations where time is of the essence, right? If I know it's a STEMI and I know they're cardiologist, I have a better sense of who do I need to call, because obviously we've got 2 groups here at Union and I have to call one group versus the other. So those are all key things to know about. So keep those things in mind when you hear it. When you're giving reports, both at bedside and over the radio, think of missed, give that report in that route. Matt had brought up a question about regional and Union having the same kind of iHearn data sheet in terms of collecting this information when you call. We'll work on that with Barry and I, and we'll try and get that as in line as possible so that everyone, so that's easy for you. So you're obviously calling the same kind of information across the board. And then the last thing I wanted to touch on was calling medical control. Now I'm available for you 24/7, right? Maybe 23/7 if I'm like in the shower or or working out for a second, but it's probably 23-ish 7, 365 days of the year I'm available for you. So please don't hesitate to call me. I'm here for you for that particular reason. Whether you have a question about the patient on scene, you're curious about, you want to give some medication, but you're not 100% sure. You want to give something that may not be within your parameters in terms of our protocols, but you think it may be in best of the patient. You want to ask me a question about it. Or what are sometimes some of the more common things are, for example, you're on scene for a cardiac arrest and you're like, hey, what should we do termination of efforts, right? So we don't call time of death. That's not in the field. That's not my job as a physician and as an EMS director. It's to do termination of efforts, right? And so inevitably the coroner will determine time of death in essence from that perspective. But when you call me for cardiac arrest, it is super key for some big pieces of information that I need to know. When was the person last seen, right? How long has that person been down for? And how long have you, or at least, CFRs or fire been doing CPR, right? What was the initial rhythm? What has been the persistent rhythm? And were there any shockable rhythms? Have we placed an advanced airway? And what's the end tidal? And then what are you calling me for actually, right? So it'd be nice for you to start. And also just the biggest thing is if you're calling me to do termination of efforts and you've been on scene for, let's say, 20 plus minutes, you've been in asystole throughout, this person is a fairly significantly comorbid patient. So let me give you an example. You get called to a scene for an 86-year-old male found down. Wife hadn't seen, let's say it's 10 in the morning. Wife hadn't seen him since 8 o'clock last night. Wife went to go check on him and wake him up for breakfast, noted that he wasn't awake, tried waking him up, wouldn't wake up. She's too weak and frail to do CPR. So she didn't do any CPR until fire got there. Fire got there 20 minutes ago. You've been doing CPR and ACLS for the past 20 minutes. Initial rhythm was asystole, persistently in asystole, has gotten 4 epi, 1 bicarb, 1 calcium, is intubated, has an end tidal of 8, and you call me for termination of efforts. What would be super helpful to do, and one thing I will ask you to do always on bedside is does family at bedside understand what's going on? Right? It's always key for you to turn to somebody and be like, this is not looking great. And these are the hard conversations, unfortunately, I have more frequently than I'd like. And it's something that you have to get comfortable with having in these particular situations. And everyone's style will be different. But it's nice to turn to the family members and go, listen, this isn't looking great right now, but let me call my doctor and see what he recommends. And we'll go from there. Right. So that they have that mindset of understanding that, hey, we may have to stop what we're doing because it's going to be medically futile. So having that understanding. Now, if you call me with an end tidal, if you look at the research out there, for most pre-hospital care things, end tidals of greater than 20 and definitively greater than 30 means that there's some perfusion going on, which is challenging because you don't have some of the resources that I have in the ER. You don't have a bedside ultrasound that you can look for appropriate squeeze because you may be getting PEA in the 20s to 30s, but in reality, it's actually a decent squeeze. It's just not perfusing enough to create a blood pressure. So that's why sometimes I may turn to you and go, with an end tidal of 20 or 30, or definitely greater than 30, I may have you transport. You should understand that that's the reasons why. We can't terminate those. The data out there and the literature out there really doesn't support that. But if you're calling, keep this story in order for me, and that will make it a lot easier for me to give you some medical control options to, right? Any questions about cardiac arrest stuff?
Hey, Doc, it's Jared Rankin. I have a question.
Yes.
Have you noticed, at least with the advent of all the CPR devices in the county and in the city, that we typically have substantially high end tidal CO2s? Because I've kind of noticed it a lot. And so I think that's kind of like we get a lot of knee-jerk reaction from ER docs when we're calling for termination resuscitation, that they're like, oh, that's a really high end tidal. And it still be like a, patient was asystolic the entire time and whatever else. I mean, what is your kind of position on that?
Right. And could be, I haven't seen newer literature because obviously remember the Lucases aren't as profusely used in the past couple of years, and they probably just haven't put the literature out. So there hasn't been substantial literature that I can point to that says that we're still terminating anything with an end tidal. We can safely terminate, right? Every situation will be different. But whether we can safely terminate with significantly high end tidals with mechanical devices. I think as that evolves, we'll have a better sense. And I'd rather err on the side of caution and make somebody come to the ED and let me kind of evaluate them there than terminate when in reality we have some perfusable rhythm that we're just not picking up as an out in the EMS field. Right. I know it's challenging, and I totally get it. Right. We're having to package this person up, get them into the rig, get them into the ambulance, get them home, get them to the hospital, and then kind of go from there. So I know those things are challenging. I was an EMT for a long time. I rode with all my medics for a long time. So I totally get it. But on the flip side, we have to give these people appropriate chances where it's possibly due. And then from a medical legal perspective, I have to be able to say, I can justify terminating efforts based on research and data that shows that it's medically futile in this instance, but I can't really say it's medically futile when somebody's end title is showing that. Now, do we need to, do some more data digging on it and some more research on it? Absolutely. But can I terminate it off of it based on that right now? Probably not.
Do you think that we'll have like a threshold maybe? So like we say, just for sake of numbers, we say if there's an end title of at least 20 and we're at the 20-minute mark, that we should go ahead and transport, or are we to that point yet? Or do you know?
I'd almost say call, because it's so going to be case by case, right? If this person has been down for a fairly long period of time and we can have an appropriate conversation and get a sense of what's going on, I think that's more appropriate than having to kind of make it blanket statement. And then that way you have a better sense of what we can do for everybody, right? We're not wasting resources inappropriately. And I hate to say the word wasting. I mean, we're not overutilizing resources that don't need to be utilized for a person. And then on the flip side, I don't want to underutilize it when it's appropriately best. So I'd rather you call if you have a question in those situations. Does that make sense, guys? Or Jared?
Yes.
Cool. And I agree. So I think let me do a little bit more digging to see if there's any more data out there for termination of efforts for people who have mechanical devices. I don't think there much is, because it's fairly new enough that nobody's really done the research out there to look at, hey, was there meaningful recovery for people who came despite end titles being X number or higher? And then the other thing I wanted to talk about was diversion for traumatically injured patients. So especially if you're coming from, the outskirts and your options are Clinton or Union or Clinton or Terre Haute or regional, you really should stop for yourself and say, hey, will this patient be best served by a trauma center, right? And is going to Clinton making the most sense for the patient? So for example, you have grandma who rolled out of bed, you do an exam, grandma's got no tenderness anywhere, her legs, she even maybe walked with you to the cot. She has no tenderness to her hips, she's not altered, she has no anticoagulants, her vital signs are stable, right? Should we send that to Clinton? I think it's probably okay to go to Clinton if you think that there's nothing there, right? On the flip side, same grandma, same problems, but grandma's right hip is shortened, externally rotated. Maybe it's not even shortened and externally rotated, but it's really quite tender, and she won't walk on it for you because it hurts so much. Should that go to a trauma center? I think so. Why? Because Clinton doesn't have orthopedics. Clinton doesn't have a trauma surgeon. So let's take her to somewhere where we get definitive care and we go an extra 20 minutes down the road, versus having that patient have to go to an ED, then have to get transferred to another hospital for more care and cost more to the patient and delay care for them as well, right? Now, if you're ever in the position where you go, man, I don't know, what should we do? What do we think is the best and not? Give me a holler. Tell me what was the mechanism of injury. Tell me what you found and seen. Tell me what their current vital signs are. What have you done so far? And then why do you think we should divert to a trauma center? And I'll talk to you about it. And you're seeing that patient, but I need the story from you so I understand what we're thinking. All right. So call us for medical control. Then obviously there's all these other options to call for medical control, but I want you guys to utilize me as a resource because I'm here for you for that particular reason. So please do send that over to us. And let me know if you have any questions about calling for medical control or about giving bedside report or IHERN reports. Okay. If not, I thank everybody for your time, and I'm going to turn it back over to Barry.
All right, Matt, can you continue to share or not? Okay.
Oh, I can. You want me to share again?
Huh?
You want me to share again?
Yeah, go ahead. Just seems to be working better from yours than mine. If you don't mind.
That was the end of my screen, but that was it. I'm done.
You're not on mine, that disregard.
Okay.
Sure mine. Come on. Are you still, no, never mind. Got it. Man, this terrible. So jumpy. All right. So be sure and email me. Let me know that you were on today if you weren't here. Additionally, to get A&R credit from now on, you have to take the little quiz that I build at the end of every PowerPoint, at the end of every EMS audit review. Okay. Sure, this is not going to work. There. There it is. All right. So if you scan the QR code, there'll be a little quiz that goes to Microsoft Office 365 and on our forms here at the hospital. I will get it. The first question, put your name in, which EMS service or hospital you work for, and then you answer the questions. There are 4 or 5 questions. It's very simple, very easy to do. There's also the link there, so you should be able to. I don't know about the link. You can't do much with that probably, but unless you, if you're on your computer, you might be able to highlight it and copy it. I don't know, but the QR code works really well. I played with it yesterday and was able to take the little quiz. If anybody doesn't have any questions, that's about all we've got for today. I wanted to take the time to say happy holidays, Merry Christmas, New Year, whatever you want to hear. That's what I like to say to you. So I appreciate everybody showing up. Guys, we're going to have this again in February. Try to come face to face. Come have some breakfast so we can see some people. We're back to being able to do that. We want to take advantage of that. Get some people in front of the screen and visit. So have any ideas for audit reviews you'd like to have? Different things, please let me know. I've got some stuff. We'll have to do some STEMI stuff and some stroke stuff, and I'd like to maybe get an orthopedic surgeon in here, do some ortho stuff too. So maybe trauma. If you have any ideas, let me know. Otherwise, thanks a lot, and have a happy holidays coming up.
Happy holidays, everybody.
Bring it.